Okay, well, I hope everybody was as excited as I was to hear the choice of music for today's jam session. I thought that was wonderful, very upbeat, and actually reminded me of the Christmas Day football game halftime show, which was fabulous. So so anyway, hi everyone. I'm Lisa Cooper, Director of the Center for Health Equity. This is our January 2025 Health Equity Jam session. Happy New Year, everyone. Welcome, welcome. It gives me great pleasure to kick us off for this year, this 2025 year, in the midst of so many different things going on. But we have a group of kind of committed and longstanding partners and scholars and community members, everyone who is with us today. So just happy to see everyone. And also pleased to introduce our speaker for today, who is Dr. Emily Wang. And she's going to be talking to us about community-based participatory approaches to mitigating the harms of mass incarceration. So, but before we get started, we have our traditions with the Health Equity Jam session. And one of them is that we do like a fun facts intro to our speaker. And then we go into the sort of more traditional introduction. So for this, we always have audience participation. So I think we'll start with that. And there's also going to be, like, before we get started too, I believe there's an announcement I need to make. So other than Happy New Year and all of that, there is an announcement that we have that the Center for Health Equity faculty members, those of you who are on the call, we did send out a research update email to you, asking you to respond with updates on your research projects and your current trainees. So no pressure or anything, but making sure you pay attention to that and respond to that. So that's the only announcement I have for now. And now I'm going to start out with our first fun fact. So our speaker has one interesting fun fact related to where she was born, right? And where she started out her early life. So I want people to take some guesses about where in the world Dr. Emily Wang was born. So let's see. What guesses do we have? I don't see any guesses in the chat so far, so maybe everybody's kind of stumped. It may not be as hard as you think. Oh, somebody wants me to narrow down within the US. I can't do that. That would make it too easy. So somebody guessed China? No. Taiwan? No. I'll let Dr. Wang respond. So we have Peru. We have a couple of different continents here. We have England. We have Canada.
The clue is in the song that introduced me.
Yes.
Yeah.
People weren't listening to the song. There you go. She hails from the great state of Texas. So tell us about a little bit about you, Emily, where you grew up and why you chose your song, other than the fact that you're from Texas.
Well, I love Beyonce. There's probably a greater performer. And I born and raised in Houston, Texas. And it's an interesting place. I don't know how many of y'all have traveled down south, and Texas is one of the only states where it was, in fact, an independent nation. And so it's one of the only states where you can actually have, one, we had to take Texas history as a requirement of being a Texan, and two, where the state flag can hang at the same level as the United States flag. So it is unique in a lot of different reasons. But it's a place where, folks will have kind of different ideas of what Texas is like. And Houston's one of the most diverse cities in the United States in terms of kind of who lives there, what languages are spoken, what sorts of food you can get. And so, yeah.
Mm-hmm. All right, cool. No, I love, I've enjoyed whenever I've visited Texas. It's so different from like any place else that I've been. So I think that that's very cool. And I like the whole idea that we're learning more about kind of the some of us anyway who haven't known, learning more about sort of the country music and the Western influences from there, and that African Americans were played a big part in shaping. So through Beyonce, actually. So, but I know it's a multicultural state and a very diverse state with lots of interesting things
Yeah.
about it. Food,
Yeah, I just
culture.
went and visited. They, you know, their prison system is run by the University of Texas medical branch of Galveston. And so, of course, as y'all know, that's why we celebrate Juneteenth. It was the last place union where um, uh, individuals who were enslaved were notified of emancipation. And so there's a very rich history that connects kind of Texas in a lot of different capacities. But, you know, so I just had the experience of talking to a lot of folks that are incarcerated about kind of what Texas is like, what the medical system behind bars is like, and also what Galveston feels like.
Wow. Okay. So fascinating. And you do, of course, fascinating work that we want to hear about very soon. And I also want to, I mean, if it's okay for me to say, Dr. Wang is going to speak to us, even though she's a little bit under the weather. So we're not going to drag this out too long and make it too hard for her because it's very gracious of her to do that. But I do want to share one more fun fact about Dr. Wang. And I'm trying to see how I introduce this to give people some kind of clue about this. Well, she's multi-talented and is able to do many things at the same time. So I'm just wondering whether you have any idea of what that's an indicator of in terms of other roles that she has in her life. And yeah, I guess that's a place to start. So what else does Dr. Wong do other than be a fabulous award-winning researcher? She's also a MacArthur Fellow, by the way. So, okay, somebody says mom, wife. That's good answer. Whenever you hear multitasking and all of that kind of stuff, being able to keep multiple balls in the air at the same time, mom. So, how many people want to guess? How many children does Dr. Wong have? And who are they? What? There's a really unique thing about Dr. Wong's motherhood that I don't know that there's anybody else on this call that shares this experience with her. So somebody said 5 children or 4. Okay. Well, okay, somebody said multiple sets of twins. Okay, so why don't you tell us who your kids are and how you managed to sort of be a wonderful mom and a scientist, brilliant scientist and clinician all at the same time.
Lots of help. I have 4 kids, and I have triplets. So a set, they're all girls, a set of 14-year-old triplets, some knee deep in teenage life, and then an 8-year-old.
That is pretty amazing. Yeah. So yeah, I would love to be in your house. Yeah, lots of girl fun. But anyway. So well, we're not going to belabor this because I know you would love to tell us about your work. So let me tell you more about Dr. Wong, like seriously. I mean, not that the other stuff isn't serious, but this is really, she's a professor in the Yale School of Medicine, and she directs a Center for Health and Justice, and I don't know whether you call it SEICH or SEACH, Center for Health and Justice, which is a collaboration between the Yale School of Medicine and Yale Law School. And that center is committed to ending mass incarceration by working across the disparate domains of health, law, and criminal justice. Direct clinical care, conducting research, and educating health students and professionals. They also drive legal advocacy and scholarship. And so Dr. Wong leads the center's research program, which receives NIH funding, to investigate how incarceration influences chronic health conditions, including many of the conditions we study at the Center for Health Equity, such as cardiovascular disease, cancer, and opioid use disorder, and they use a participatory approach. She is an internist and has cared for thousands of individuals with a history of incarceration, and is also co-founder of something called the Transitions Clinic Network, which is a consortium of 48 community health centers nationwide that are dedicated to caring for individuals recently released from correctional facilities, employing community health workers and with histories of incarceration. So, you know, a lot of her work, you can tell she's one of us, right? And a trailblazer at that. She has been inducted into the National Academy of Medicine, and of course is a MacArthur Fellow, a superstar plus wonderful person. So without further ado, I'd like to turn over to Dr. Emily Wang, and let's welcome her warmly.
Thank you so much. It's a real honor to be here. I'm going to go ahead and start sharing my slides. And, you know, before I start, do y'all hear the feedback now? Dr. Cooper, when you were talking? Okay, great. All right. There's a little feedback. Okay, can you see my slides? Super. So I just really so appreciate being in community with you all here today. And I am under the weather. My cheeks are usually not this rosy blush, but really kind of grateful to be here. And I'll start by kind of making certain we're kind of on the same page, which is just to say that 2023 marked the 50th anniversary of mass incarceration. And this is probably a term that's common to most of the folks here on the call today, but it's a term that's used to describe legal and policy decisions that led to a massive expansion of incarceration as punishment and restrictions on public social services and civic life following incarceration. And this means laws on the books for the last 50 years that stipulated that people with criminal records, 80 million individuals, could not have in certain communities access to food, housing, employment, or even vote. And by all accounts, after these 50 years and among bipartisan leadership, it's seen as having been largely ineffective in keeping our communities safe, in reducing crime, and far too costly. And its effects, of course, are largest among Black people, poor people, and have had profound effects on population health, both among those that have been directly impacted who've been incarcerated, but also family members whose loved ones are incarcerated, and even communities where there are high rates of incarceration. And so one key thing as we start considering kind of policies to undo this harm, a key asset that's been really locked out of conversations about how to undo this harm are individuals that have been impacted, those with histories of incarceration. And so I'm going to start this today, our talk today, with a flashback of our first cohort of Transitions Clinic Network community health workers. I was 15 years younger at the time. These individuals were all incarcerated. And I start here just to remind us that these people are the biggest assets to our science, to health system transformation, and that it's they that really can explicate what are the health harms of incarceration and the paths forward. Through the years, often, and I'm sure you guys get this too, comments about this is God's work, this is feel-good work. And in fact, I think critical here is just understanding that including their expertise, it makes our science more rigorous. It simultaneously reminds us of the urgency of this work. And it is with them and in partnership with them that we've been seeking solutions that really enable their perspectives, values, and expertise to be embedded into the very scientific structures, the systems, the practices, and the policies that create a more robust and thriving community. And so what I'm going to do is talk a little bit about my experience with CVPR, working with them, some wins, some challenges, especially our work in capacity building. And in doing so, I hope that I can share a little bit of what we've learned and then learn alongside you all. And so what I'll do is often folks don't have a full kind of understanding of incarceration over these last 50 years. So I'll give a brief background of the demographics of mass incarceration. Then I'll talk about the health risks of incarceration, and really drill into how healthcare systems behind bars and post-release influence these health outcomes. And then shift to how we can use CBPR to address health impacts of incarceration, and try to describe kind of multi-level approach that we're taking to strengthen community engaged research among those with histories of incarceration, and then end with some concluding thoughts. Okay, so there are currently about 7 million individuals that are under the jurisdiction of the criminal justice system now. That's 1.9 million individuals that are behind bars in prisons and jails at any given moment. And just broad strokes, kind of basic definitions, jails house those that are awaiting adjudication of crime, and so lots of throughput. And then individuals that have been sentenced with a crime and serving sentences typically of less than a year. So lots of individuals, and interestingly, the denominator isn't well captured, but it's about 7 million, 10 million, depending on whose reports, that move in and out of these jails. And then prisons house those who've been sentenced of a crime and are typically serving greater than a year's sentence. And so about 1.9 million individuals that are incarcerated. And then there's about 5 million individuals that are currently being supervised by community corrections. That's on parole or probation. Parole are for those that have been sentenced of a crime, in served time in a prison and are released back into the community. And probation are for those that have been sentenced of a crime and served their sentence largely in the community. And so all told, that's about 7 million individuals that are currently under the jurisdiction of the criminal justice system. After 5 decades of these policies, it's about 79 million adults in the United States that have a criminal record. And then when you think about kind of expanding out to family members, there was a great study that was published that found that half of all adults in this US, in the United States, so 113 million adults, have had an immediate family member who's ever been in a prison or jail. And so this is the kind of touch of the criminal justice system over these last 50 years has been large and has large reaching impacts that often, I think, aren't well understood by providers, researchers, and even health equity researchers. Those who are incarcerated are disproportionately poor men of color. Using life table measurements in 2021, data from the Bureau of Justice Statistics, these researchers were able to estimate that it's about 1 out of 10 men have had a lifetime likelihood of imprisonment. And this is just prisons, not time into jail. And when you break it into race and ethnicity groups, what you find that for white men, it's about 1 in 20. For Black men, it's 1 in 5. And for Latinx, it's 1 in 8. And this disparity has changed some, but not a lot over the last 5 decades. Similarly, while incarceration is far less common among women, Black women are much more likely to be incarcerated in their lifetime. And, you know, when you think about kind of at the population scale, what does this actually mean? So there's an amazing sociologist, Becky Pettit, who's now in Texas, actually. And the New York Times ran a headline based on our work. There's about 1.5 million Black men who are missing from daily life between the ages of 25 to 54 because they're either dead or incarcerated. This is one of the infographics from that Times article, which show then the yellow places where Black men are missing. So again, dead or incarcerated, in purple places where they're overrepresented. And, you know, while it's long been known that Black men are more likely to be locked up, more likely to die young, the scale of this combined toll over the last 50 years is large. What it means is that more than 1 out of 6 Black men aren't around to be parents, husbands, working citizens. Higher imprisonment accounted for 600,000 of this 1.5 million. and early death accounted for 900,000. Homicide then was the leading cause of death for young African Americans in heart disease for older Black men. And this missingness of Black men especially has significant bearing for our understanding of the health of Black men, of health disparities, the measurements of health disparities, and our achievement of health equity. And so I'm just going to dig into this thought a little bit more. So if incarceration is incredibly common, and it's common among Black men and a driver of premature death, we want to see if researchers are accounting for the exposure to incarceration in diseases of health disparities. And and in particular, we dug into cardiovascular disease, which is where my K award was funded. And so we identified all studies funded by the National Heart, Lung, Blood Institute, which followed participants, Black and white participants, for at least 2 years. And first off, asked how many of these studies, and you can see them on the left-hand side, followed, like in their IRB application, got approval to follow their participants over more than 2 years, right? 2 years, or even some of these have been going on for 30 years, into a prison and jail. How many do you, oh, I actually can't see the chat, so I'll just pretend. And as it turns out, probably not a surprise, none of them have IRB approval to follow their participants into jail or prison. How many ask about an exposure into prison or jail? And again, these are things like Cardia, Jackson Heart Study, MESA, like where we get a lot of epidemiologic data on differences in groups, right? And again, only one of these studies out of all the ones that are on the left-hand side asked about exposure to jail. Of course, it's Cardia, where they had 2 questions at baseline and year 2. And so again, these studies don't provide the opportunity to understand about incarceration, but actually have a lot of missingness due to incarceration probably in their study. And we wanted to find out just how much that might be. And so because they didn't measure it, we had to estimate it. So these here then are, again, data on Black men that are missing from health cohort studies due to incarceration. The red is the actual loss to follow-up in these studies. And the blue, what we did was, again, took data from the Bureau of Justice Statistics, looked at the year of recruitment, looked at places where they're recruiting, and then estimated how much, what was the likely percentage of individuals that could have been incarcerated in the times of recruitment. And what we found here was that, again, in these studies, anywhere from 15 to 65% of the loss to follow-up in these studies was due to incarceration. And again, these are just estimates. But the point that we're trying to make with this is that the scale of which we've incarcerated and continue to incarcerate has to be impacting our knowledge of health disparities, as most studies don't follow individuals into prisons and jails, don't include institutionalized participants, and don't even ask about an exposure to incarceration. All right. So now that I've given you an example of how incarceration impacts the study of health disparities, I want to shift to talk about how incarceration directly impacts individual health and the healthcare system. And, here I often get asked the question by doctors, why are these patients any different than those with substance use disorder? Why are they any different than those that are poor, homeless? From researchers, it's the same question, but asked in a different way, is this incarceration and exposure to incarceration actually an independent risk factor? Is it actually causal? And, I don't think, come so far now that I don't think I'm really ever going to answer this. You're not going to have a randomized trial that tests this out. And so just by face validity alone, I'm going to show you pictures that come from the California Department of Corrections that were shared by permission of what the experience of being incarcerated is like, especially if you have a chronic health condition. Try to make the argument alone based on just face validity. And then share with you some studies that we and others have done using observational data to build on that argument. All right, so I had a longitudinal primary care practice in San Quentin, which is the oldest prison in California, when I was a resident at UCSF. It was a place that kind of was a place where I was first exposed to what healthcare behind bars looked like. And with this first picture, just wanted to share with you is that often the media gives us the impression that those who are incarcerated are kind of this young, healthy group. And in fact, the reality is that about 80% of individuals who are incarcerated have a chronic health condition that warrants longitudinal primary care. They include physical health conditions, just like this gentleman has here, like COPD, asthma. They also include hypertension, diabetes, hepatitis C, substance use disorders, and mental health disorders. So it's about 80% that have a chronic health condition. And what really kind of attracted me to this field, and again, it wasn't something that I really learned in medical school, but kind of shook me to the core once I learned it, is that healthcare is constitutionally guaranteed in prison. It's one of the only places in the United States where there's a constitutional guarantee to care. And so what it means is that for a large segment of the population, especially young adult men, this might be their first time accessing healthcare behind bars. And our research and others show that about 40% of individuals are newly diagnosed with a chronic health condition while they're incarcerated. Now, even though there's a constitutional guarantee to care, access is limited by institutional policies. And I share with you this picture here, and just to turn your attention to this pink slip, so it's a kite. And it's a little form that patients have to fill out when they want to see a doctor. And then as was the case in California, it's not there anymore, but still the case in many, many carceral systems. This form is then evaluated by a correctional officer. And then if the correctional officer deems that there's medical necessity, then a nurse, and then after that, a physician. And so you can imagine that there's lots of barriers before you go and actually get to see a physician to address any kind of acute or chronic issues that you may have. Unlike in the community, that even if there's barriers, you always know you can roll up to the emergency department. This just simply isn't the case. Another example is that individuals have to pay a copay when they're incarcerated. And in California, in Connecticut, where I live, it's $3. So $3 copayment to see a physician. Now, that may not sound like a lot, it's $3, but when I tell you that the average person, if you actually have a job behind bars, makes 75 cents a day, then it's equivalent to 4 days' work just to see the physician. And so you can see that while healthcare is constitutionally guaranteed, there are unique and different barriers to accessing healthcare when individuals are incarcerated. This photo comes from the daily rounds of a patient who's getting his blood pressure checked, was diagnosed with hypertensive urgency, was discharged, was admitted rather to a community hospital, and then returned back to the carceral facility, and we're doing kind of like a discharge follow-up visit. And, immediately I just want you to notice that this is the circumstance under which we're evaluating healthcare. It's not private. There's nothing confidential. You just threw the blood pressure cuff through the hole. Of course, it's not being put on correctly. And so there's just not a lot of space to have kind of confidential conversations about healthcare. Every morning at the crack of dawn, this person's woken up by a correctional officer, led to a med line, and is newly given his lisinopril hydrochlorothiazide, given it a cup, pops in the mouth. The nurse checks to see if he's cheeked it, and then he goes back to his cell. And so while you can see is that adherence is almost 100%, it's incredibly passive. He doesn't have to learn how to take the medication, doesn't call a pharmacist, doesn't know what to eat and when to eat as it relates to the medications. And so, if you think about the activated patient that we're trying to create in primary care, this is antithetical to the activated patients. Like self-management takes on lots of different and really contradictory forms when individuals are incarcerated. The quality of care is very variable in correctional systems, and probably even more importantly, it's rarely measured. Perhaps the best example of this is in the treatment of opioid use disorder. So opioid use disorder is highly common in carceral facilities because we've criminalized drug use. And just to give you a statistic, in a national survey, about 40% of individuals who use heroin have spent time in a prison or jail in the last year. And so, again, these are the most at-risk individuals that are moving through our healthcare systems in carceral systems. And so despite the efficacy that's known for our 3 FDA-approved medications, methadone, buprenorphine, and now naltrexone for reducing death, it's really just methadone and buprenorphine, but also return to carceral systems, these medications are only available in some prisons and under certain circumstances in a few jails. And in the last survey, it's around 5% of facilities. And this is in part because the decisions about what's on the formulary, the decisions about the delivery of healthcare services are decided by correctional officers and sheriffs and not doctors about whether and what sorts of medications are available. So, you know how in the community we have a whole system of reporting. JCO comes to the hospital, we are all worried. There's quality metrics on which they're publicly shared, and then funding comes. This is not the case for the 6,000 carceral facilities that are in the country that are delivering healthcare to millions of individuals that cycle through each year. And then lastly, I think it's important to share here, this is a photo of a patient, much like the one that I started with, who has COPD and is oxygen dependent, and who's being held in solitary confinement and requires oxygen. And it's impossible not to notice, but you can see that the tank is outside this window and the tubing passes through this jarred window. And so you could hear the person having to knock each time when the tubing got kinked and he couldn't breathe. The rationale, of course, is that in the carceral system, it was too dangerous to have the tank inside. But what's clear to me is that health is secondary to punishment, to control, to safety. And you have to imagine how this patient must see physicians, healthcare providers as being complicit in health-harming behaviors. Physicians and nurses were passing by. And of course, then, how do you then trust systems that can treat you in this way? So I think it's important to remember that this isn't just a behind the bars problem. Almost everyone comes back home. 95% of individuals that are incarcerated come back home into the community. And over 3 years' time, among those that have been released, 67% will go back into the carceral system. Over 5 years' time, 75% will go in. And so we've created a system where there's a lot of cycling in and out of these two very different, very siloed healthcare systems. So what happens when folks walk out the door? There's really minimal discharge planning. And individuals are given a short supply of medication, sometimes 7 to 30 days, and usually released without their health records. And so you can imagine for those 40% that are newly diagnosed with a chronic health condition, they don't know how to call the pharmacy. They don't even know what, like how to do it, when to do it, where to do it. They have to set up a primary care provider. They have to maybe get specialty appointments. They have to connect with an opioid treatment provider, et cetera. And then also get food, housing, employment, et cetera. Many are released without health insurance or have had a lapse in Medicaid and Medicare. Interestingly, there's lots of new policy, which we can touch on later, but for this talk, maybe I'll just breeze through this now. But what this means is that individuals with Medicaid in many states, they suspend Medicaid when you're incarcerated, and then you have to go back and reapply. And so if you don't have your ID, you don't have a way to actually, like meet your basic needs, this is just one other thing that you got to take care of before you can see a healthcare provider. Not surprisingly, there's discrimination based on criminal health, based on criminal record by healthcare systems. And then, as I alluded to at the beginning of the talk, there's barriers to meeting basic needs because of these collateral consequences, laws that are on the book that limit individuals with certain criminal records from ever, lifetime, getting food stamps, WIC, Section 8 housing. And so, not surprisingly, a host of health risks that follow release from a correctional facility. And I think that this is an important part of the talk, which is to say, imagine what you will, whatever you want to, about the carceral system state of health, right? We don't know much about quality or delivery, but every single study has shown that actually among those that cycle in and out, it's always worse when they come home compared when they're incarcerated. So the onus is on us as community health providers. And I think that that's like a key part just to remember. It may suck inside, but really we're doing a terrible job in our own communities. There's a worsening in chronic health conditions that include HIV, hypertension, cancer, substance use disorders. Our team has led some of the studies in hypertension, cancer, but really across all conditions, there's a worsening. There's a high risk of hospitalization and a high risk of death that are largely preventable. And these are from conditions like opioid use disorder, overdose, heart disease, cancer, suicide, and then gun violence. So some of these conditions are largely preventable with engagement in primary care. And, I pause here just to say that, often it's the carceral system that's under scrutiny without taking a hard look at what we're doing in the community. And I want you to think about, as I often do, about what Yale's doing or what Hopkins is doing, where we have ceded power to the carceral state. A patient of mine recently told me that they were shackled in Yale while getting intrathecal chemotherapy. So that's, for those of you that aren't healthcare providers, that's a very small needle passing through your spinal fluid to transmit chemotherapy. Who is going to escape or run while they have a needle inside? Or providers at Yale that are really concerned that they have patients that are shackled when they're intubated in the unit. And so I think key among kind of what we're trying to do is really start thinking about how do we undo this harm? How do we create spaces that are really kind of ones that anchor health and healing that are really not replicating these systems of control and punishment. And so this is an ideal place, in my opinion, to use CBPR to undo this harm, to change community health systems, programs, policies, and to invert normative power structures. And so during residency, almost 20 years ago, as I mentioned at UCSF, I became obsessed with what I thought was kind of a small issue at the time of transitions of care for people released from carceral systems. I thought we deal with transitions all the time. So how hard could it be to just transition the care of people that have been incarcerated back home to the community health system? And with another co-resident, Clemens Hong, we're in San Francisco, we started focus groups with a robust environment and vibrant community of civil rights leaders that have been fighting for the rights of people that are currently and formerly incarcerated. And with them and in partnership with them, designed a model of primary care that centers people with histories of incarceration as experts in the delivery of care. And here is my late colleague and friend, Jerry Smart, our first community health worker, who leads that delivery of care. And in so doing, wanted to shift the paradigm of primary care. So instead of this gentleman coming home, and not knowing how to navigate the healthcare system, the first person they meet inside is Juanita Alvarado. She's a community health worker. She meets him inside, starts to assess his needs, his social needs, his health needs, and comes up with a plan. Says, I'll be there for you. This is how you're going to reach me. This is what we're going to do. And she is the first contact for that patient following release. Then they see a healthcare provider. Here's Levis Owens within 2 weeks of release, knowing that the risks are incredibly high at that time. This is a provider that knows that there's a healthcare system behind bars, knows how to get the medications, knows how to communicate with the Department of Corrections, and then slowly over time, addresses in partnership with our community health worker, the social determinants of health, their concerns that are often largely more important or equally important to their health needs, including kind of future contact with the criminal legal system through parole or probation. And so wanted to create spaces within primary care where we talk explicitly about the harms of mass incarceration, where we open conversations talking about how is it that we can keep you safe and well at home. And so as a first step, of course, we developed a community advisory board. This included, of course, our patients, and we asked them to define who were the primary stakeholders that should be at the table. And this included here all sorts of individuals from our San Francisco Reentry Council, the Mayor's Office, the Department of Public Health, even jail medical staff. Our patients wanted to have those individuals at the table, and health system leaders. And as the program grew, among many things that was discussed in our community advisory board, they wanted to design a study. And here I'll just pause, is that oftentimes, there's kind of these notions that it's unethical to design randomized trials. Our patients wanted it. They wanted to think about how it is that we create data that would enable the sustainment of this program, that would evaluate it most effectively. And so we did design a small randomized controlled trial where that they felt was ethical, where everyone got one transitional visit within 2 weeks, and then they're randomly assigned to either continue getting care in transitions clinic or an expedited appointment within the safety net within 4 weeks that then would continue them. If you think about the outcomes that we looked at, which is like administrative data from the electronic health record in county jail, these are so boring to me. But these are the outcomes that our patients and our community advisory board wanted, because they understood that this is how power moves, this is how resources move, and if we could cut costs to the city, then programs would open that would hire those with individuals with criminal records into the health system. And so this is how we moved forward. And fast forward, again, under having enrolled 200 individuals, and it was biasing towards the null because everyone first got a 2-week visit and they were randomized. What we did find was that there was a reduction in emergency department visits. So 40% of individuals in the standard primary care compared to 26%. And then overall, TCM participants had 50% fewer emergency department visits in the 12 months following release. We saw no differences in their return to jails. And so, this is an example of how we have used and then continue to kind of partner with individuals who are incarcerated in our research. This program now has been under the leadership of Shira Shavit at UCSF, grown into a program that now has 14 states and Puerto Rico. We've provided primary care to about 10,000 patients leaving correctional facilities and have really studied it. And if there are more time, and I can talk about this later, we've looked at all sorts of different healthcare use patterns in different systems, but also studied return to prison in other contexts, and have found that it saves the state costs, especially in reducing kind of parole revocations and probation revocations. And it's in partnership with policymakers in these community health systems and payers to implement the TCM model. And also, of course, our patients who have histories of incarceration, that we've been able to work to expand these programs. And it's through this work that I think CBPR is most profound in its sustainment, which is that recently, in April of 2023, CMS finally announced for the first time that Medicaid funds could be actually allocated to payment of healthcare services of incarcerated people through these 1115 reentry Medicaid waivers. And essentially cited Transitions Clinic Networks, cited the workforce of those with criminal records as a key component to transitioning care from carceral systems back home into the communities. And to me, I just wanted kind of to take pause, which is to say that there aren't other national programs that kind of have bridged care from carceral systems to the communities. And without evidence, of course, I don't think that people would be as eager or apt to hire those with criminal records to work in the health systems. But it's because of the leadership of people with histories of incarceration at policy tables in their state legislatures that have made these programs spring up all over the state, and thus have led to kind of CMS taking this on. And so to me, it's an example of, again, how CBPR is this place where by active engagement from the very beginning, and this is now 20 years after, you can move policy. It's the slow incremental path, but that really enables and opens doors to build careers further. The TCN then, of course, has been a place where we've studied other and continue to study other research questions. Right now, we have a randomized trial of people with opioid use disorder released from jail. This is ongoing now. It's being funded by NIDA, a multi-site study where we're looking at this. And are finding things like, of course, there's a high burden of exposure to the criminal justice system. There's high initial exposure to medications for opioid use disorders. That's good news in these 5 jail systems. And the average number of overdose in our participants was more than 5 times. We're just at we've just hit finally enrollment, our enrollment numbers. So still we're waiting on outcomes to come. But what has been a challenge, I think, through kind of these last 15 years is really this tension of how we can both create spaces that provide rigorous research, but also really still anchored in the delivery of primary care, what that looks like over time. Through transitions, what I think is, and especially through TCM PAS right now, there's real tensions between kind of community capacity building while attempting to build, maintain, conducting a high quality randomized controlled trial on 5 sites. And still yet many funding mechanisms don't account for the time and resources that are needed for community engagement or CBPR. But, you know, to me, the balance of kind of enabling sustainment through policies and then doing rigorous research, it's a balance always, and one that I haven't totally figured out, but I think important to keep pushing our way forward. In this work, we have, of course, then started using CBPR to transform institutional practices. And I'll start by giving just a very brief background of the SAISH Center. In 2020, I had the opportunity to create this new center at the School of Medicine that's a partnership with the Yale Law School that's really focused on ending mass incarceration. And it's anchored again in the delivery of healthcare and transitions clinic network. And through patient care, then that informs research, our educational initiatives, and legal scholarship and advocacy. And a SAISH wave, which is illustrated here, this is so poetic, and of course I did not come up with this. Our team members who've been incarcerated did. So a SAISH wave, and you can look it up, is a meteorologic term, essentially that emerges when in stagnant water. So you can see pictures of this on like Lake Michigan, where there's waves erupting in 2 waves and then out of nothing explodes a wave that disrupts the status quo. And so they see us as disrupting the healthcare system and the criminal justice system. So this is a SAISH wave. And at the core of the SAISH Center then is clinical providers that are working across all these different domains. My gosh, it's very, very animated. Different domains to try to disrupt the 2 systems, the healthcare systems and the criminal justice system. And the ways that we've designed the SAISH Center in particular is that the majority of individuals that work in our center, from staff, faculty, and students, are directly impacted. So really trying to create spaces within the center itself that honor that sort of expertise. Our research program has tried to focus in on the highest causes of morbidity and mortality. And so we have grants that are focused on overdose, heart disease, homicide, cancer, and COVID-19, and now thinking about vaccines as well as vaccine uptake. And I think it's important just to say that it's in this research in particular where in working alongside people with histories of incarceration, they have switched kind of the questions that we ask. So instead of asking, who, what's wrong with the individuals that are incarcerated, what's wrong with family members, what puts them at risk, you start asking questions about what are the structural supports necessary for thriving. And so more recently, we have 2 studies right now where we're looking at giving home loans or down payments. It's a neighborhood cluster randomized trial, giving home loans or down payments to family members whose loved ones are incarcerated and looking at its impact on community health outcomes. And another grant where we're giving unrestricted cash assistance to individuals that are coming home. And so, again, trying to kind of shift the questions that we ask, really start to think about what are the sorts of trainings, capacity building and institutional reform that really needs to be changed. And so we've tackled this at the individual level, the study team level, and then of course the health system, university, and the community organization level. And I'll just give some examples of ways that we're trying to take on that work. So one big issue, which I'm sure y'all have talked about in this setting, is that oftentimes CBPR, again, you're trying to kind of create leadership and have individuals with histories of incarceration, in our case, involved in all aspects of the research, including analysis. And often that creates and presents the largest problems. With PCORI funding, we created something we call the Patient-Powered Research Network, where we created an informatics platform where we shared the data back of our own study of study participants and had kind of used user-centered design tools to create a web-based tool where people that have histories of incarceration, community health workers, could work alongside health system leaders, correctional system leaders, study the data, understand the data that were coming from the study, and then propose their own hypotheses. So trying to create the tools that enable all individuals, no matter what your data literacy skills are, they're not learning R, but all the data are there. You can actually analyze it to then start thinking about what are the next questions? Have we analyzed them wrong? What are kind of possible results that we're seeing from this study? At the community level, one of the things that we've tried to do is that across our research studies, increasingly, when you're community partnered, you still, even if you're co-leading, it's not true partnership. And so we were trying to think about how it is that we can build community organizations to actually co-lead. And some of the policies we've taken on at Yale is trying to create at-risks, and I'd be interested to hear what y'all do, at-risks for community organizations, try to make it easier, again, for the execution of invoices. We're starting trainings to help community organizations actually negotiate or even renegotiate their indirect rates. So, Yale cuts, I think, 69%, and I'm sure Hopkins is just as high. These community organizations are cutting their 13%. And so how is it that we can create equity in budgeting and even participatory budgeting, and then trying to create data systems that that our community organizations can better use to comply with the accounting and the kind of different reporting structures that NIH requires. And then lastly, we've had to shift institutional policy, and Hopkins is actually a leader in this. We actually talked to Hopkins HR to define this, but we've been working for a long time with our human resources department and legal counsel at Yale to make our hiring policies around people with histories of incarceration transparent, listed on the front of the application site. This is what we do. Have an appeals process, have a system whereby we can look and measure what are the results, how many people are applying with criminal records, what happens to them, what parts are they turned down, if they are accepted to employment, what are outcomes like. And so really excited to say that after years of working on this, have finally created a hiring policy at Yale that had input from people with histories of incarceration, has data that's transparent, that's reported, and that will be iteratively adapted and hopefully kind of changed based on those data. And then the last bit too is that it's not just hiring kind of staff and researchers, but also trying to think about whose expertise are honored. We now have 2 MPIs, women, both of whom have been incarcerated, who were the first at Yale that have criminal records, that are now School of Medicine faculty. And that took some doing, as you can imagine. So these are the ways that we're starting to kind of create spaces in Yale that both honor different sorts of expertise and create different pathways for those with histories of incarceration to really inform our science. And so a new frontier that we're taking on is trying to do CBPR in prisons. This is a grant that's funded by NIMHD, looking, as I alluded to, on vaccine uptake. It's being led by, it's kind of blurry, Dr. Lisa Puglisi, who directs education in SAGE Center, Saad Omer, who is a vaccine expert, who's now the dean at the University of Texas and Southwestern, and Deanna Hoskins, who runs Just Leadership USA, which is the largest national organization of formerly and currently incarcerated individuals. And this has been an incredible opportunity, but also a challenge. You know, if you're trying to invert power structures, there's probably no place that's harder, I think, that within a prison, in my opinion. And the things that we've been able to do successfully is that we did convene a representative community advisory board where correctional workers, so staff workers, leaders, health system leaders, and also incarcerated people participated in a community advisory board. And the way that the grant was designed is that they together would identify novel and feasible interventions using a participatory process to then do these rapid randomized trials. Well, there's nothing rapid in prisons as it goes, so it hasn't been rapid. But what has been successful is that we have identified some novel and feasible interventions behind bars, including using cosmetologists, which would be the first kind of cosmetology intervention ever tried in a carceral system. We've trained formerly incarcerated Just Leadership USA fellows in qualitative research as part of this grant. And then the challenge is, let's say, you know, turnover staff is pretty standard. But, you know, I'll just skip to like food and space for gathering, which has been very interesting. You know, a key component of CBPR is you must have food in these meetings, right? You're trying to build community, build relationships. And you can imagine that when we've rolled up, of course, we're there for a day long, we're definitely feeding them good food. Well, the incarcerated members of our community advisory board actually could not participate. They had to be escorted out back into their cells. And so this created immediately a surprise tension for us. We didn't expect it. And it raises lots of other questions for us about how best to create opportunities for community building in a place that is structurally coercive, period. The second is another example. So the space for gathering also is, and again, we have to rely on our correctional partners, right? So the first time they gave us space in the administrative building was this glorious room, huge. And we're like, this is good, this is perfect. They escorted our community advisory board incarcerated individual members in. And later we found out that those individuals caught slack for 30 days. Because there's no reason that an incarcerated person ever would be in an administrative building unless they're snitching. And so the space, again, because actually very few people have tried rapid randomized trials and very few people have really tried to convene and do this participatory work in carceral systems. The space for gathering actually matters a lot. The second time, of course, we heard that, we're in the educational rooms now, and that's a place where incarcerated people go all the time. And so this didn't present the challenges that being in an administrative building did. And so there's lots of learning, but also lots of internal questioning about how it is that you can power share, build relationships in places that are structurally coercive, and even whether or not it's worth doing. And so, you know, I'm going to end here by just saying that for us and our team, CBPR is an approach that really has kept our science rigorous. It's urgent, it has been able to shift power and can lead to sustained change. And I gave you one example within TCM, but there's others that we've experienced. It's a strategy which is useful to challenge hierarchies in healthcare and universities, both through evidence and also through relationships. I can say that as we've brought in more and more people with criminal records and actually changed the the hiring policies for criminal records, more individuals, of course, are coming into Yale working, and they're just awesome members of our community. But it's also places that each time still, sometimes I'll get calls from the dean, I'll still get calls about this hire and this not. But as they see and meet individuals, of course, as y'all know, it breaks deeply held ingrained biases of people that take that relationship to undo. And then lastly, I think it's been a huge place of personal growth, but by far the place of the deepest joy. So I end with this note that comes from an incarcerated student of ours. In fact, Lisa is his MPH advisor. He's still incarcerated right now, Michael Stokes. And I'm just going to share this with you as kind of an end food for thought, because it's getting at the crux of, should we do research in prisons? Should we do research in carceral systems? And we've been trying to send all of our teachings at the SAGE Center, all the educational offerings, we always send it back into incarcerated spaces. And so after a webinar focused on COVID, we got this letter from Michael, and it's, another suggestion. So this is about kind of vaccine trials startup in carceral systems. Another suggestion I have would follow my questionnaire idea, of course, of gleaning data from it, would be setting up a pilot program of inmate volunteers who would either participate in ongoing clinical trials for COVID-19 or any virus for that matter, or human challenge trials, like the one that Rose participated, and he goes on. And I think that this raises questions for me, like the most profound questions of who's excluded from research, who reaps the benefits from research, why incarcerated people, the millions of individuals, have never been included about scientific governance, and the deep need to start shifting our norms to include these folks, these brains, into our science. And so I end here. I'm really excited to take questions, and thank you so much for this opportunity.
Thank you so much, Emily. This has been phenomenal. I mean, so inspirational and exciting. And I'm sure that so many others on the call are feeling similarly to me. I see a lot of hands are up. So instead of me taking the prerogative of asking questions, I'm going to, can you see the hands that are up, or would you want me to at least call on folks for you?
I can see them, but I don't see any up.
I thought I saw some up before. Maybe people put their hands down, or maybe they were just clapping. But I see Chidima has her hand raised. But just before you speak, Chidima, I was just going to say that a lot of the challenges that you shared, Emily, some of them are the same challenges we have, but of course you've had mentioned some that are very unique. And I just want to say that we are just like in awe of the fact that you have remained committed and have kept the stamina for this long, and have really sort of elevated the voices of people that are so marginalized, and and brought like scientific rigor to answering these questions in a way that policy has been influenced. So I'm going to say that. I'm going to turn over to Chidima to ask her question, and I have to answer the door at my house, and I'll be right back.
Yeah, well, first of all, I really echo everything Lisa said. I wanted to just mention that I've heard of you for years from Clemens Hong, actually. I met him in 2013, and he spoke so highly of you. So it's really such a pleasure to hear from you today, and to be inspired by all the great work that you're doing, which is so hard and so complex, and just so multi-layered. So I really thank you for everything that you've done, and for really emulating what it looks like to advance a program of research that is so impactful and so meaningful for members of structurally disadvantaged communities. Um, the question I have to ask you actually is more kind of like from a perspective, um, what would you say is really the biggest lesson that you've learned over the past, 20 years or 20 plus years of doing this work? What would you say to the next generation of community-based participatory researchers who, want to imitate the kind of work that you've done and the way that you've done it?
Well, that's in this very deep space. I think I was even talking to Dr. Golden about, about how it is that you kind of create a path forward and then, keep on keeping on, and how you make decisions. This work is really joyful for me. I mean, I'll just start that. It's like it's hard work. It is hard work, but there is just nothing more. You know what I showed you, the community health workers, the very beginning. Those are folks that I've known, every single one of those people I know so deeply, so well. We've gone, I don't mean to, and I hope I didn't present this when I was talking, that it's not a place of like, oh, really Pollyanna, or like everything's just fun, and then we did this, and then and it's now policy. I mean, it's like we've gone into places of real deep conflict, really kind of questioning like what it is that we're doing. But at the root of the root, it's really joyful that there's and to me, I think that that's important, is that you can lose sight of that. It's like, oh, and then your K, and then another R1, and how are you going to get that P funded? Or, oh, wow, that IRB, or my God, I didn't reach in. Like, there's all sorts of other stuff, or even worse, that community health worker just passed away. These patients, like, we've had a spate of 4 suicides recently where we're not doing enough, or even more, it goes deeper and deeper. And to me, the reason, if I look outside, it's a fun group of people, because it's in this hardship, it's in kind of the relationships and the lives that they've led. It's like we still eat meals together, yuck it up, dance, in fact, Beyonce's often playing. And so to me, I think that that's one thing, is like what gives you joy, and then kind of anchoring there. And for me, it's being around folks like Jerry, who I mentioned, who passed away, but many of my team members here who've been incarcerated. And I think it's partially because they've lived through something that's profound, that's kind of inexplicable, and then it creates this urgency. So you feel pumped, when we see patients, and I think that that's the part. And I know that not everyone here is a physician researcher, but I still see patients in primary care, people that have been incarcerated, because it just keeps it urgent. Like doesn't feel like an abstraction. It's an every damn day that I'm thinking about this, because I just saw a patient. So that keeps it new and fresh. But I think, like, if there's one thing, is like anchoring kind of a career in joy. Like, what is joyful? How do you kind of, and maybe a more radical form of joy, like it can still feel hard and be joyful at the same time. I don't know.
Thank you. That was beautifully said.
It is. It was, and it certainly rings true for me as well. I mean, yeah, people ask, a lot of times will ask, like, how do you keep doing, what you do? And it's like, well, it's because it's so deeply rewarding. It's more rewarding than so many of the other things that I could be doing that might be easier, but you just don't have, you don't really have the sense that you've made that much of a difference. But when doing this work, even if it's just one person at a time, it makes a big difference. But then when you're working with community partners and you're working with organizations, you can see that it's more than one person at a time, that it's a whole system that's shifting and changing. So I definitely, what you said rings true for me too. I'm wondering if there are others on the call. I think this is just like the perfect way for us to start off our year. Remembering that, and just also remembering that, seeing that data about the fact that almost half of people, even though they may not have been incarcerated themselves, know somebody who has been. This is a problem that affects like a lot of us. In many, many ways. And so, not remembering that we're not that far removed from it, and that many people are unjustly incarcerated. so that you don't even have to necessarily have really done something wrong or committed a crime to find yourself in that situation either. So I think that's also very sobering. But I'm talking a lot. So does anybody else have anything else to say? We won't belabor it because we know Emily is really soldiering through all of this. And we really appreciate that. If no one else has more to say. Oh, there's Katie. Were you going to say something?
Hi, Lisa. There's some questions in the chat. Sarah Pollock put some questions in the chat that I think are very interesting.
Oh, sorry. Well, I see one that says that people want contact information or want to make sure that there's access to the recording. Oh, wait, I see now. Where does the funding for the TCN clinics primarily come from? And can you comment on developing relationships, partnerships with prisons and jails?
Yeah,
This is from Sarah Pollock.
great.
Yes. Hi.
Hi, great. These are two great questions. So, clinics are kind of like, it depends on what state the clinic is based, but they're embedded within usually federally qualified health center, community health centers. And so like the funding for a program per se, the provider pays like fee for service or covered for managed care. The key part that's underfunded, I know y'all know this at the Center for Health Equity, is community health workers, right? And so across the 50 states, the issue is that sometimes they're not billable services, sometimes they're billable services that are fee for service that are under reimbursed, right? Or in the large part of most states, there's no funding mechanism for community health workers. And so for the bulk of kind of the 15 years, many of these were either the FQHC just believed they had a champion. And so what they would do is hire the community health worker that has a history of incarceration and move forward. That's one model. Two, grants, right? Like, and then in certain places like San Francisco and then in North Carolina, I'll give you two examples, the Department of Public Health took it on. Right. So they saw the data, they see cost savings, they know there's a benefit. So the Department of Public Health pays for the community health worker. In North Carolina, which I just bring up, is like, you never know who's going to be excited about this, right? Like you never know the interests that, hey, creating healthier communities, but saving taxpayer dollars might create a reducing return to prisons and jails. So in North Carolina, in a state that is very purple, and also has not still as of yet, even though they approved legislation, but has not actually formally expanded Medicaid to this population. There was the governor and the medical director of the Department of Corrections was really interested in trying to think about how it is that the resources of the Department of Correction could shift back out into the community. And in a huge kind of justice reinvestment, they pay for now 13 community health workers out of the DSC budget that goes shifted line item from the DOC to the DP, Department of Public Health in California. My God, this is my sickness, North Carolina, to pay for these community health workers. And so and then in Connecticut, that's a whole other story. We've still had some real barriers. What is the opportunity now? And if you're interested in looking into this more, are these 1115 reentry waivers. So Medicaid had these Medicaid inmate exclusion policies, and for the first time in CMS's history is going to enable states to apply for these waivers to allow Medicaid to reimburse for care 90 days prior to release. And so that gives the opportunity, if states have so chosen, based on the CMS guidance, to think about scaling up programs like transitions. And HRSA recently just had a big grant announcement. 51 community health centers now are being funded to provide care in these transitional kind of from carceral systems back into the community.
Oh, thank you, Emily. There's one more question from Mackenzie Lewis about as someone who wants to get more involved in direct care and research with this population, do you have any recommendations on where to start?
Yeah. Well, I'm assuming that you're in Baltimore at Hopkins. Is that right, Mackenzie?
Yes, ma'am, I am. I'm actually an occupational therapist at Hopkins, and I work a lot with patients that are incarcerated. So I see the issues with the transition back to the correctional facilities.
Great, 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 great. And you know, perhaps like Dr. Cooper and others would know kind of what are the programs that are available within Baltimore. What I can say is that there is, I don't know if you know Carolyn Suffren, so she does work on incarcerated populations, especially women, that might be a place to start. And there's probably others that are very, very kind of juxtaposed to incarceration, but Carolyn is probably the person that I know the best at Hopkins.
Okay, can you repeat that last name for me, please?
Yeah, Suffrin, Suffren. She's an obstetrician gynecologist.
Awesome. Thank you so much for this presentation. It was incredible.
Oh, sure.
Yes, we know Carol, and we've collaborated with her on other projects, but
I figured. I mean, and there's probably others there too.
right. But we get a broad cross-section of folks coming to the jam session. So not everyone is connected with everyone else. So, but it is a nice kind of place for people to come together and get to know one another. Is someone else? I see Dr. Lin, you have your camera on. Do you have a question?
Hi, hi, Dr. Cooper. I just want to say hi. I'm I guess a product of TCN's grant program. So really happy that you were speaking today. Went to Harbor UCLA for residency. So we set up our REACH clinic using one of the California grants. So I think the question earlier about where the partnerships can come from or how to kind of get things going. Outside of FQHCs, you also have your residency programs and academic medicine. And so even at Hopkins, we do have a carceral medicine rotation for the urban health folks. But the way that I ended up working closely in the LA jails was because there was a kind of academic position available in the jails to bring residents to rotate. And that's kind of how we based our REACH model afterwards. So for folks who are maybe looking for how to build it, kind of going through the academic side, going through the funding that can come from there, especially for our CHWs, was helpful for us. And the residents really got a lot out of it. The medical students really got a lot out of it too. So I think that's just to remind that's a great kind of way to set up this type of structure. So I'm in Baltimore now, but the Harbor UCLA program is still running and running well. So thank you very much.
Yeah, it's nice to meet you.
There's another question from Sarah Pollock about whether there are doctoral student research opportunities.
Oh yeah, we you know the answer is yes, I suppose. There always is. I mean, we right now I'm trying to think if we have doctoral students that are working on the TCM paths. We certainly are. So Dr. Lauren Brinkley Rubenstein has a number of doctoral students that are kind of conducting analyses based on TCM paths data. So yes.
All right. Well, thank you so much, Dr. Wang. This has been fabulous. As you can tell, everybody was so excited, and it was so enlightening and inspiring, as I said before. And we look forward to possible collaborations with you in the future and to continuing to follow your trailblazing work. And as I mentioned before to everyone, we will have a recording of the presentation for people who missed it on our YouTube channel. And yeah, we look forward to seeing the rest of you next month. And to Dr. Wang, I know our paths will continue to cross. So thank you again. We really appreciate you spending your time with us despite not feeling well.
Thank you.
Everyone else, have a wonderful rest of your week. Everyone have a wonderful rest of your week, and take care of yourselves.
Bye.
Thank
Good
you.
to see you. Okay, bye-bye.